Okay, and we're live. Good afternoon. Welcome to Ask the Docs, a Fertility Institute of Hawaii live stream. This month, we'll be talking about Polycystic Ovary Syndrome Awareness Month, and our topic is PCOS and infertility, seeking help and solutions. Thanks for joining us today. We've got a lot of great information to share with you guys. My name is Dr. Carmone, and we have Dr. Fraterelli with us here. Dr. Goulet may join us in a little bit as well. All right, so let's kind of get started with what is Polycystic Ovary Syndrome?
Well, Polycystic Ovary Syndrome, or PCOS as it's commonly called, is really a misnomer. It's not a bunch of cysts on the ovaries. It's really a lot of follicles that people will have on their ovaries typically, but not always. It's, in general, a disorder that causes a multitude of symptoms for patients. And it's not this, every patient doesn't have the same symptoms, so it can be a little bit complex as well. Some patients will have irregular menstrual cycles, so it can affect your hormone levels. And so that you have irregular cycles, or you don't menstruate. Ultimately, you don't ovulate. That's one of the criteria. You can have lots of follicles on your ovaries but not cysts, but just a higher number of follicles than should be average for your age. Or you can have what we call hyperandrogenism, which is elevated androgen levels in the blood, and that can be either a blood level that we find, or it can be manifested by other symptoms, such as abnormal hair growth on certain parts of the body that aren't common for either your ethnicity or other patients and your other family members. And this probably wasn't the best definition of it, but would you like to add something to that, Dr. Carmone?
I thought it was a really good definition, which is what I'd like to add. But I think
it's confusing because it's not just a simple, oh, this is what it is.
Right. There are a lot of different theories to what PCOS actually is, where it comes from. And there are a lot of different ways to define it, which is kind of the tricky thing. There's sort of a constellation of symptoms. The truth is that it's probably more than one thing, and depending on the severity of PCOS, there are different treatments that are recommended depending on the goals. But a few things to think about. So there's the sort of health risks, and then there are the implications to fertility. It is extremely common, depending on the definition that you use. About 20% of women will meet the criteria. So if you're one of those women, you are in very good company. And the very kind of basic criteria is that you have to meet one of three things, right? So or two of three rather. So you have to have, you could have either lots of follicles in your ovaries, okay, or you could have irregular periods, or you can have lab evidence of hyperandrogenism, like an elevated testosterone level, okay, or clinical signs of hyperandrogenism, like the excessive hair growth and things like that Dr. Fraterelli was talking about.
And I didn't mention acne as one of those.
Acne, right, is a clinical sign. So if you have kind of two of these things, you meet the criteria for polycystic ovary syndrome. Okay, if you only have one of these things, then technically you don't. Although I sometimes talk to patients about it and say, well, you may sort of be on that spectrum, because the definition at times can be a little bit random. The implications to pregnancy are that there may be some issues with trying to get pregnant. The implication to long-term health is that if sort of left uncontrolled, there may be higher rates of diabetes for certain patients. And there may also be higher rates of endometrial cancer And again, this is mainly in patients who don't have regular periods and who aren't kind of doing anything to manage that.
And actually, just to stress that too, the endometrial cancer risk is for because people are not ovulating or not menstruating and shedding their lining, and so the way to mitigate that is to have regular menstrual cycles. And typically, for patients with PCOS, that's birth control pills or some progesterone at a regular time interval, or an IUD, for instance.
One interesting thing about PCOS that I like to bring up to my patients, I don't know if you guys know this about me, but I was in anthropology, double major, like anthropology and biology. So one of the interesting things.
I did not know that, really.
You didn't know that? Okay. Well, it was one of those liberal arts schools.
On our podcast.
There you go. Okay. I was an anthropology and biology major. And so one of the interesting things about PCOS, and actually most diseases that have a very, very high prevalence, or they're very common, right, is that they're usually somehow beneficial, or they were beneficial at some point. For example, the big one is sickle cell disease, right? So if you're a sickle cell disease carrier, you're less likely to get malaria. Okay, so because of that in the population, right, it's sort of propagated because people were less likely to get malaria. Similarly, cystic fibrosis, that's another kind of big one. People who are cystic fibrosis carriers are less likely to have cholera. Okay, so all these things which used to kind of benefit us don't benefit us much anymore, but it's already been kind of propagated in the population. Something like PCOS that is common, 20% of women have PCOS, it's got to have some benefit, some evolutionary benefit. And it seems like the theory is that women who had PCOS may have been slightly less fertile. And so, not completely infertile, so they could still have children. But, maybe back in the day, they were the women who didn't have 10 children, 20 children, and, sort of die and all their kids starved, right? So instead, they had smaller, kind of healthier families. And because testosterone levels were higher, they may have had some benefit in terms of strength and the ability for physical activity, back when that was really important for survival. And so I didn't just make this up. This is written up in anthropology papers. Okay. And so the thought is that, there actually is some evolutionary benefit to polycystic ovary syndrome. But of course now, and that's why women who, also develop diabetes with time, because there actually is a type of metabolism that sort of was favored during sort of starvation periods and things like that aren't as favored today. But I bring this up as it's kind of can be kind of a neat thing to think about when you think about why PCOS has been propagated in the population. But in today's day and age.
Okay. And I think I have heard that before, but it's not something that's I guess it's common knowledge, right?
Yeah, it's sort of an anthropology thing. So regardless, though, obviously we want to treat it at this point to help prevent some of those long-term risks. Yeah.
Well, I was going to mention some of those, long-term risks. With PCOS, obviously there's a hormonal imbalance, right? And so, you have an underproduction of estrogen, you have overproduction of androgens, which cause the symptoms that you're seeing. But then there's a range of other endocrine and metabolic, issues that patients can have. That, not all PCOS patients, but there is a higher prevalence of being obese with PCOS. They'll have lipid issues, insulin problems, glucose. They'll have glucose issues where they may develop diabetes, or a higher risk of developing type 2 diabetes, and ultimately cardiovascular disease. So all of those things are, risk for patients as well with PCOS. So when we see them for fertility, those issues aren't necessarily always addressed because they may not be manifesting those yet, but certainly that's something that they have to be concerned about as they move along in their life.
Yeah, and when I
Welcome,
think
welcome, Dr. Goulet.
welcome, this is Dr. Goulet. So when I think about PCOS treatments, I think the goals, the sort of immediate goals, are extremely important. So there's kind of the long-term risk that Dr. Fraterelli was talking about, and then there's also the short-term, like, do you want to get pregnant right now? And the treatment for these two things are pretty different. And so if you are seeking pregnancy, then the path is quite different than if you're not, because if you're not, oftentimes the treatment actually involves potentially suppressing the ovaries a little bit to try to get those hormones in balance. Dr. Goulet, did you want to talk about some fertility treatments for PCOS patients?
Sure. So with PCOS, a lot of times the eggs are stuck at the starting line. That's the comparison I make. And they just need a little bit of a nudge in order to grow those eggs so that our patients will have a cycle, that they'll ovulate and then have the withdrawal of the menses about 2 weeks after they ovulate. We do have out on the market very affordable, very effective medications that can be taken orally that do a very good job in the majority of PCOS patients in inducing that ovulation. And we call that ovulation induction. And so with those oral medications, historically, we used to use Clomid. Recent data has shown that letrozole may be a better medication for our PCOS patients. Letrozole was initially invented as a breast cancer medication. So if you Google it, you might see all of the scary things that the FDA writes can cause bone pain and hair loss. And that's not really true in the doses and in the how we use it for fertility. So I caution my patients not to get scared when they hear that it's a breast cancer medication. It is an off-label use, but it is very good for our PCOS patients at growing that egg and leading to an ovulation. The majority of individuals do respond very well to either of those medications, but some individuals might also need something more aggressive, such as injectable gonadotropins. And those are those fertility shots that would be dosed and given in an injectable pen in the belly over a course of time. Now, with both of these medications, if we're doing either of these treatments, they do have to be monitored. So we would recommend ultrasounds in order to track the growth of the eggs, because with PCOS, when my patients come to me and they say, oh, twins run in my family, what I'm thinking is it's probably PCOS that runs in your family, and these meds can stimulate the growth of more than one egg at a time.
That's right.
And I guess, just to add on that a little bit, I guess, because patients oftentimes will say, how does Clomid or clomiphene citrate or Femara or letrozole, how do they work? And I think the easy answer for patients is they increase your FSH production in your brain, which allows allows you to have that follicle to grow. And oftentimes the way I explain it to my patients is you have so many follicles in your ovary, your brain only makes so much FSH. There's not enough FSH to go around to spread out through that cohort of follicles that you have, so that one can become dominant. And so we have to increase your FSH a little bit just to allow one follicle to become dominant. And so that's kind of the way that the Clomid and the aromatase inhibitors or the letrozole will work as well.
Yeah. In terms of the treatments, the other types of fertility treatments like in vitro fertilization, intrauterine insemination, those may also be needed for PCOS patients, but not necessarily, with different criteria. In other words, if somebody is unsuccessful with the first line therapy for polycystic ovary syndrome, which is ovulation induction, we would move on to, intrauterine insemination or in vitro fertilization, in a similar fashion to anybody else who kind of doesn't carry the diagnosis. When we're thinking of in vitro fertilization for someone with PCOS, the big thing we have to keep in mind is that patients with PCOS are much more likely to kind of overstimulate and potentially develop a syndrome called ovarian hyperstimulation syndrome, or OHSS. With the modern protocols and medications that we utilize, severe OHSS is rare, even in patients with PCOS. But nevertheless, that's kind of more of the consideration for patients with a lot of follicles. They're the ones that we kind of have on lower doses, and maybe kind of keep them on those low doses for longer to try not to recruit quite as many eggs. We don't need to get 100 eggs from anyone, so we just want to get a couple of good ones, right? And usually patients with PCOS kind of do well in that regard.
I wonder if, I think something maybe we've missed so far, maybe Dr. Goulet, you may want to talk about it, is metformin.
Oh, yes. So metformin. So, and I know I came in when you were talking about the long-term concerns about PCOS, but one thing that, and so I'm not sure if you had mentioned the insulin resistance, but I'm guessing you probably did.
We did a little bit.
Very briefly, but yeah, feel free.
Yeah. So with PCOS, we do see a very significant number of individuals that also have some degree of insulin resistance or diabetes, and those medical comorbidities become more pronounced with time. So the older you get, the more likely you are to develop insulin resistance, glucose intolerance, and diabetes. And what we know is that, if you're having prediabetes, that's not good for egg quality. And so treating with metformin can help improve your egg quality. But we also have studies that show that in conjunction with Clomid or the letrozole, it can help synergize and help those medications work a little bit better. Clomid, the metformin by itself, people had tried to use it as an ovulation induction agent, and it's not really much better than placebo. But if you add it together with the letrozole or the Clomid, we do see a little bit of a synergistic effect, making the letrozole and the Clomid more effective.
And I would also add that you also, with the metformin, will see a lowering of the androgen production as well. So you'll see androgen levels that will decrease associated with that as well. And so that may be another benefit of metformin.
Yeah, there may be some benefit, especially for patients who are resistant to one of the medications. But just to clarify, if a patient is ovulatory with letrozole or Clomid or whatever, there may not be much kind of additional benefit to giving them metformin. It may be helpful to make patients more sensitive to one or the other if they're kind of resistant to it. And I just wanted to address some of the questions and comments from our patients here. So one viewer has said, thank you for our daughter, Ellie, who is now 6 years old. You're so welcome. Okay. And then somebody else here is asking, what is your opinion on using naltrexone to help with ovulation induction for PCOS? And so I want to comment that there are not a ton of data yet about combining that with agents for PCOS specifically. But there are data for some of the other agents. One of them is metformin, using that synergistically with the other medications, and the other medication would be a steroid like dexamethasone, which is very, very useful for patients who are resistant to Clomid or letrozole. Any other thoughts about that? Okay. Let's see, what else have we kind of not gone over? Kind common misconceptions or myths surrounding PCOS. I think the big one is that all patients with PCOS have to have irregular cycles, which is not true. We kind of talked about how you can have regular cycles and still have PCOS, which may still cause some, little bit of ovulatory dysfunction or issues with hormones or egg quality because of the hormonal imbalance, even if there's regular ovulation happening. Another misconception is that all patients with PCOS are heavy, or that you're going to cure PCOS by losing weight. That's not true. So you may alleviate some of the symptoms, especially surrounding the regularity of menstrual cycles, but you won't cure PCOS by losing weight. It's not that's not really even sort of part of the criteria, for PCOS. So just to clarify about that. What else?
Well, and along those lines, I get a lot of patients that mention to me, this prior doctor suggested maybe I have PCOS because I am overweight. And I think that it's as you just said, it's not one of the criteria. And there is a lot of, I think, misconceptions where people assume, because you're overweight, you must have PCOS. And that's often not the case. And so you can have problems ovulating that occur without having a diagnosis of PCOS, and they often get confused.
Right. And I think there's a lot of intersection there. So I don't want to, because there's insulin resistance, it can be harder to lose weight, and the hormonal imbalances can make things more difficult. And so it's not that they're not associated with each other. It's just that weight loss may help with the symptoms, but won't be sort of curative. There may be a spot here now for us to just mention that there are surgeries that used to be performed and that some people are still performing for PCOS, which I feel like people don't really do anymore, but I think there are some physicians who are still offering it, at least as of a couple of years ago.
Yeah, those surgeries, the ovarian drilling, I feel like they're not anybody's first choice. I mean, I've done them, you've done them, we've all done them, I think, at one point in time. What this is it's a laparoscopic procedure where we put a camera in the belly and we take an electrocautery and we literally burn holes into the ovary. And it's been shown to make the ovary more effective at ovulating. This is called ovarian drilling. I think the instances where I've done them are usually because of insurance coverage, where insurance won't cover any other sort of fertility treatment or PCOS treatment, or they've tried other fertility treatments and they're not working, and it's the last resort sort of procedure. Here in Hawaii, we're very fortunate. We have very good coverage for fertility treatment, so we're often not needing to resort to such invasive procedures such as ovarian drilling.
I mean, anything that really damages the ovary is going to, improve polycystic ovary syndrome, because it's really it's a syndrome that comes from that kind of ovarian production of these hormones and the multiple follicles that are there. And so actually the other thing which naturally makes PCOS a whole lot better is if you're in aging and just getting older, because the follicles become atretic. There are fewer and fewer eggs around. And so, that's kind of depressing for some of us. But for patients with PCOS, they might actually find that all of a sudden their cycles are kind of getting more regular. And that could signal that their ovaries are just aging. And, in this case, it's not necessarily a bad thing.
Yeah, I mean, both. Yeah, that's a great point. I will add to, I guess, the surgery point. Initially people were doing wedge resections of the ovary, which really wasn't a wedge resection. You basically just remove half the ovary when they were doing that. And essentially, when you're doing the ovarian drilling, you're just damaging the theca cells, and so you're lowering the androgen levels that the ovary is producing. And that's how you're helping, right? And going back to lifestyle changes and weight loss, I don't want people to think that we don't promote that, right? So if certainly if someone is obese with PCOS, one of the first things we're going to say is, lifestyle changes, right? You need to have a better diet, exercise routine if possible. But I think I also talk to my patients with PCOS. It's difficult for patients to lose weight sometimes. Not everyone can lose weight very easily, and so it's not something there where we make them do anything. But we always want to suggest that if you don't have a proper diet, have a better one. If you don't have an exercise routine, get one. You don't have to start running a marathon or anything, but you just need to do something to make yourself a little bit healthier if possible. And that may or may not help your fertility, but it may in fact help your pregnancy if you are pregnant. The healthier you are going into a pregnancy, the better off you're going to be. And so I always kind of explain that to them as well. But I don't necessarily tell them to exercise and diet for 6 months and come back to us, because the benefit to fertility is probably very minimal, if any, with that. So, but definitely there is a pregnancy benefit for patients. And the other thing is there's no diet that's really recommended. It's just, a healthy, well-balanced diet, so, decrease your calories in some way. If you eat a lot of sweets, stop. If you eat a lot of meat, red meat, stop. Or not stop, but cut back, right? It's hard to make big changes to a diet. You have to really make small changes that people can then, live with for a long period of time.
Right. And it's also important that it's really the dietary pattern and not one thing. So people are like, what should I eat or not eat? There isn't one thing. One type of dietary pattern that kind of sticks out that is a little bit easier to follow in our part of the world is the Mediterranean diet. I know we're not in the Mediterranean, but it's sort of one of those things that makes really a lot of logical sense. So low carbs, but not no carbs, lots of leafy greens, lean meats, lots of vegetables, oily fish like salmon, olive oil, balsamic vinegar instead of kind of heavy salad dressings, and red wine if you're going to drink alcohol, not when you're pregnant, of course, although they probably do that in the Mediterranean. So that's the kind of thing you have to think about, is just sort of a little bit changing the pattern altogether and not necessarily completely cutting something out. And it has to be, unfortunately, it has to be a diet that we got to live with long term. It can't be a short term kind of thing. One supplement that patients always ask about, myoinositol, which is a supplement that may be similar to metformin in some studies. So that is something that appears to be safe and kind of okay to try for people who have polycystic ovary syndrome. Especially metformin can have a lot of kind of side effects. I have to run and do a procedure. Sorry, I have to run and do a procedure. So I'm going to go do that and leave you guys to it. I did want to mention that there was a patient here who's trying to schedule a consultation, so we can reach out. But because I know lots of people see this, this patient was mentioning that she's trying to call to schedule a free consultation. So we don't necessarily have free consultations. We have consultations that are typically covered by most insurance plans, including many of the Aloha Care Quest plans as well. So certainly we can help you schedule that, but I didn't want people to kind of see that and think that we have free consultations. Okay, thanks guys. Thanks for joining us.
All right, so Dr. Goulet, now you and I get to talk.
All right.
I wanted to comment about the inositol. Maybe you can too, because you're much younger than I am, and it was not, we were not necessarily using it during my residency and fellowship, but I do know that it's something that has kind of taken on, and a lot of patients will ask about it. There were two recent, there are lots of studies on it, but two recent Cochrane reviews, which really didn't show that it was really useful in improving pregnancy rates or by birth rates or decreasing miscarriage risk or anything else for patients with subfertility. But it may have some benefits, for like metformin and the metabolic profile.
Right. And I even came across one of the studies that suggested continuing that throughout pregnancy may help lower the incidence of gestational diabetes, similar to how metformin works. So myo-inositol or inositol, it's available over the counter. It's easy to take. It comes in a powder form. You can add it to your yogurt or your oatmeal or your juice. I see it's often included in a lot of the fertility supplements now. So if you're buying a fertility supplement over the counter, it's along with folate and a lot of other ingredients. That's usually one of those that they list in it. People tolerate it very well. I don't have my patients coming back and complaining of the side effects of it. And it's one of the easier supplements to take. I think that it's certainly worth trying, but even though there have been some studies and some meta-analyses on it, it hasn't been rigorously studied in large double-blinded randomized controlled trials. So we can't really say, is it effective or not?
Right. And I think you may not remember this. I think I was maybe in fellowship when it happened. When the first papers for metformin came out, looking at and saw that there was a huge decrease in pregnancy loss, early pregnancy loss for people who were on metformin as opposed to who aren't on metformin, which is why metformin really started taking off for fertility. But subsequent studies show that really that's not the case. That the two groups, there was a very high miscarriage risk in the patients who weren't on metformin for some reason, and that's not what we typically see with patients with PCOS. And so that when other studies were done that were a little bit better controlled, what we found is that there's really not that effect, because initially they were saying we should keep metformin on for the first trimester to lower that effect. And again, that the data were so compelling initially that a lot of people started doing that until other studies kind of came out. I don't know. Do you remember that? And you probably were in grade school at that time, or
when I entered training, metformin was not one of our go-to medications to keep pregnant women on to treat their diabetes or their gestational diabetes. However, I have seen the pendulum swing a little bit. Insulin is always the gold standard for treating diabetes in pregnancy, whether that be gestational diabetes that's uncontrolled or diabetes that was diagnosed prior to pregnancy. But I think metformin, it's much easier to take than the injectable insulin. And so I have seen that there has been another favorable swing back to the metformin, because it is the only oral medication that we do have some safety data on as far as it being okay for the fetus. It is, I believe, a class B in pregnancy. There was another oral medication that we were using more often that's pretty much gone by the wayside now. And so for individuals who aren't very good or have a hard time with taking the insulin and aren't very out of control, the metformin may be a better way to treat that. And so we see higher incidences of gestational diabetes in pregnancy and diabetes in pregnancy in our PCOS patients because of that insulin resistance that often accompanies PCOS.
I guess we can kind of wrap it up with just a few final comments. One thing is, what we do fertility, and so for people who are looking to get pregnant, oftentimes PCOS patients, there's a high prevalence of the PCOS patients seeing us because of that, and it's important to realize that there's a lot of different ways they can get pregnant. They can get pregnant naturally. We can give them hormones just to help them ovulate better, but and also, likewise, there's only so many ways to get pregnant, to get the egg and sperm together, right? So there's intercourse for a heterosexual couple, there's intrauterine inseminations, putting sperm into the uterus, and there's IVF. And certainly PCOS patients kind of will get treated with all of those as well, depending on what their other diagnoses tell us, and how they're responding. And they do very well. I mean, the key thing is age. It's an age-related egg quality effect. So even how old they are, you know, as long as we can get the egg and sperm together, you know, they have a very good chance.
Right. Nobody wants an infertility diagnosis, but if you have to have one, PCOS is the one that you want. If I had to bet on which of my patients would be most successful at achieving their pregnancy, it's the PCOS patients.
Why?
Oh, because they are fertile myrtles. They have been saving up their eggs. They just need a little nudge in getting those eggs to release.
And I think, you know, along that line for, you know, for my patients, you know, if they get to IVF, you know, the PCOS patients, it used to be thought, oh, the egg quality is not as good. That's really not true. The egg quality is great, and they get more eggs. And so, and with IVF, as humans, we do not reproduce very well. Okay, mice produce really well. Every egg makes a pup. As humans, it takes 10 to 20 eggs to make a baby on average. And so, the PCOS patients, if they're doing IVF, it's a numbers game. They get more eggs, so they ultimately cumulatively have a higher success rate a lot of times.
Yes.
Anything else to add, Dr. Goulet?
I think we've covered most of it. I wasn't here for the first part, but.
Well, I'm glad you were able to join us. I know you were busy with a patient, I understand, and we understand, but thank you for joining us. And thank everyone for joining us today. This is the Ask the Docs, Fertility Institute of Hawaii live stream. For more information, please check out our website at ivfcenterhawaii.com. If you have any additional questions, please leave them in the comments below, or contact us directly. And we hope you will join us again next time. Aloha.